Yeah, thank you very much, Dr. Shiban, for joining us in this meeting and for all the cooperation from Sky. And I would like Dr. Brian Pinto also to keep him alive. Live.
Sure.
Brian, we are not seeing you. You are coming and going. Okay.
Yeah.
So today are the days of confusion in relation to antiplatelet therapy. You have seen just now Dr. Nagendra Bhupati talking, and you've seen many other trials where should you use one antiplatelet therapy or two antiplatelets? Should you use it short period or long period? Which one, and so on. And let me add to this confusion by bringing in another aspect, that is, why not anticoagulation? Okay, so this is actually a concept. Why not use a low dose NOAC, especially RIVAROXABAN? These trials, whatever are done, are all done with RIVAROXABAN. In coronary artery disease patients, there are other subsets also which we are going to see. And of course, this is over and above antiplatelet therapy in patients with coronary artery disease, peripheral artery disease, and so on. The dose that is used here, the low dose RIVAROXABAN, is called the vascular dose. Why is it called vascular dose? This dose brings down the chances of ischemic events, while at the same time not particularly increasing the bleeding events. So for this reason, they have given it a fashionable name called the vascular dose. And let's see this data. Okay, 1 second. Yeah. Now, what does this show? The impact of various, parameters in relation to. Can you just help me in removing these photographs on the top? Okay. I'll speak like this. Okay. Now.
No, sir. You can. There's a minimize option on the top of the 3 photographs. You can click on that.
I have done it. I'm comfortable like this. Now, what is the impact of prior ischemic events or stable atherosclerosis on CV events at 4 years? Now, on the y-axis, you see a combination of CV death, myocardial infarction, or stroke at 4 years following one of these things. If it is a group of prior ischemic event, the percentage is 18.3% at 4 years. If it is stable atherosclerotic disease, it is 12.2%. If it is only risk factors, it is 9.1%. So you see there is a huge incidence of events, whether it is death, MI, or stroke at 4 years following any of these groups, and therefore something has to be done about this. Now, when you look at it, is this percentage, would it vary depending on whether the patient has polyvascular disease or no polyvascular disease? It does differ. What they mean by polyvascular disease is that patient has cardiac as well as peripheral artery disease, or cardiac as well as cerebrovascular disease, and that is what is called the polyvascular disease. So the patient has polyvascular disease, this percentage goes up to 25 in the first one and 17 in the second group. Now, if you look at diabetes, if the diabetes is there for these patients, it goes up to 22.5% in the first and 15.5 in the stable atherosclerotic disease. So depending on the presence or absence of polyvascular disease or diabetes, this incidence varies. So if you have a patient with diabetes and polyvascular disease, you have a high incidence of events over the course of next few years. Now, this concept has come for quite some time, because we know that atherosclerosis is actually atherothrombotic disease. In almost all situations, there is a thrombus. Merely giving antiplatelets will not suffice, and antiplatelets are important, but there is another component, which is thrombosis. You know, there is so much evidence for it: acute coronary syndrome, peripheral vascular disease, and so on. Therefore, people came out with this idea that why not combine this and give anticoagulation for these patients. Now, this is not a new idea. Warfarin was tried in coronary artery disease a long time back in a trial called VARIS-2 trial, and then there were other smaller unnamed trials, and there are meta-analysis and so on. What happened in this is, when vitamin K antagonists were used alone or in combination with aspirin, they reduced the risk of recurrent MI and ischemic stroke. But any benefit which was accrued by that was offset by at least 2.5-fold increase of major bleeding. So you have protection from anticoagulants, but at the same time, a significant rise in bleeds, and because of that, there is a lack of net clinical benefit, and therefore today vitamin K antagonists are rarely used for secondary prevention in coronary artery disease or peripheral artery disease. But what happened over the course of time is, in addition to vitamin K antagonists, you have got now these beautiful drugs called the NOVAX, the new oral anticoagulants, which are more predictable, which do not vary from patient to patient, and which do not need repeated monitoring like vitamin K antagonists. And there are many trials done in combination with NOVAX and aspirin. Let me show you some of these trials. One is the Atlas ACS TIMI 46, which was published in 2009. This also tried rivaroxaban low dose, 2.5 or 5 milligram BD. There was aspirin underlying as a common treatment to both the placebo group and rivaroxaban group. Atlas ACS 2 TIMI 51 is an extension of 46 trial, and this had the dual antiplatelet therapy in the background. Gemini ACS also had dual antiplatelet therapy. Some of these trials are relatively smaller trials. The Compass is the trial that was relatively recently published, and this had a whopping 16,574 patients, and this is the trial about which I'm going to speak in a little detail. Now, Compass is the design like this. It had 27,000 patients, and there are three arms. One is rivaroxaban 2.5 milligram BID plus aspirin 100. There is another group which had rivaroxaban 5 milligram BD with no aspirin, and the third group is aspirin 100 milligram per day, and these patients were followed up for 3 to 4 years. Now, this is a multi-center trial, 602 sites in 33 countries, and the inclusion criteria for this are the presence of coronary artery disease or peripheral artery disease. Coronary artery disease is defined as anyone having myocardial infarction in the last 20 years, or having stable or unstable angina with multivessel coronary artery disease with or without symptoms at this point of time, and multivessel PCI done in the past, multivessel CABG done in the past. Any of them is the inclusion criteria. And the peripheral artery disease is, it could be somebody who has undergone iliofemoral bypass surgery, limb bypass surgery, angioplasty to iliac infrainguinal arteries, previous limb or foot amputation for arterial vascular disease, history of claudication, abnormal ABI, carotid artery stenosis documented and undergone treatment, and so on. Now, the outcome, the primary outcome is a combination of CV death, stroke, or myocardial infarction. Secondary outcome is, of course, a combination with this, the acute limb ischemia when it is combined, and the death is coronary artery, coronary vascular disease death, and of course the other things, mortality alone also is a secondary endpoint. Now, what did the primary outcome show? Here clearly the low dose rivaroxaban plus aspirin is the winner, and the aspirin alone fared worst in terms of cumulative risk of death, myocardial infarction, and stroke. You can see that these graphs are diverging, and aspirin alone had actually highest events, and low dose rivaroxaban plus aspirin had the best outcomes at the end of 3 years. Now, this is the cumulative incidence of individual components of adverse limb events. They not only looked at coronary events and stroke events, they also looked at limb events. And here again, the rivaroxaban plus aspirin has fared best, because of our, it goes with the general feeling that peripheral artery disease, the thrombotic element plays a much bigger role. And here, from this entire group, they have subdivided the study, and this is the subgroup of those patients with peripheral artery disease, and it looked at the outcomes of each of them. A tells us the coronary events, B tells us the peripheral vascular events, C tells us the combination of both, and D is the bleeding events. And you can see A, B, C, all of them, low dose rivaroxaban plus aspirin actually has done better than the only aspirin group. Bleeding complications are, of course, slightly higher, but you know, I'll tell you about the bleeding complications a little more in the next slide. Okay, this slide shows that what are the subgroups: diabetes, smoking, coronary artery disease, symptomatic PAD, PAD lower extremities, EGFR low or more. All these subgroups, the low dose rivaroxaban has actually done very well. Now, these are the bleeding complications in these patients. You can see here, the left side column is this low dose group, the middle one is rivaroxaban alone, and the aspirin alone is the third one. You can see that there is not much difference in the bleeding events in most of the time. except that gastrointestinal bleedings were little more in the group which received rivaroxaban plus aspirin. The other areas, there is not much of difference in bleeding complications. That is the beauty of this low-dose rivaroxaban. We knew it from the earlier atrial fibrillation trials like REDUAL, PCI, and Pioneer, about which I will briefly touch upon. And you can see that with this data, that this low-dose rivaroxaban plus aspirin not only reduced the events, but also did not increase the bleeding complications significantly. Now, conclusion from this is rivaroxaban plus aspirin was associated with a 1.3 absolute risk reduction. The relative risk reduction is 24%. It provides further evidence that use of rivaroxaban in addition to background aspirin is effective in reducing thrombotic outcomes in patients with established atherosclerotic disease. Now, in fact, the data is so compelling that the monitoring committee has said that you have to terminate this trial prematurely, and 1 year ahead of the schedule, the trial was terminated. People have looked at it differently. Some people say that this should not be done, and perhaps, who knows, there may be some adverse effects later, but this is what it is, and they have terminated this trial at the 1 year before the schedule because of compelling evidence of a benefit. Now, there is another trial I would just like to touch upon called the VOYAGER trial. This is done in peripheral artery disease patients, and here these are patients with extremity peripheral artery disease undergoing revascularization, either surgery or endovascular therapy, and were randomized to rivaroxaban 2.5 BD plus aspirin versus placebo plus aspirin. And outcome is, of course, death and acute limb ischemia, amputation, MI, stroke, and clearly the low-dose rivaroxaban is a winner. Acute limb ischemia is reduced, and almost all the parameters are reduced. There's a slight increase in the bleeding complications, but like in the earlier trial, there is no increase in the fatal bleedings or major bleeds. The conclusion is, among patients with lower extremity peripheral artery disease undergoing revascularization, rivaroxaban plus aspirin is associated with reduction in major adverse limb and cardiovascular events compared with placebo aspirin. So the results are almost similar to that of COMPASS, although this is a smaller trial. Here, the background of both CAD and peripheral artery, here PAD patients, but they looked at both the outcomes. Now, in this trial, you can say that low-dose rivaroxaban plus aspirin reduced major CV events in stable atherosclerosis. The net clinical benefit while examining irreversible outcomes appeared numerically greater in those with diabetes. In fact, diabetic patients also performed well, but whether the patient has diabetes or no diabetes did not make much difference. In fact, there is a PCI subgroup also of this COMPASS, where also that history of earlier PCI did not make a difference and patients benefited equally. And let me quickly show you two very well-known atrial fibrillation trials. The Pioneer A of PCI, which used rivaroxaban in a very similar dose, 2.5 milligram BD, but they used DAPT. And of course, they also had a VKA group, and they also had a high-dose rivaroxaban with clopidogrel. And Pioneer AF and REDUAL PCI are almost similar in their pattern, and both of them showed that when low-dose rivaroxaban was combined with a P2Y12 inhibitor, the benefit is actually very good, and the bleeding complications were least. Therefore, I'm actually a little bit disappointed from this, that in COMPASS trial, they should have actually combined this low-dose rivaroxaban probably with a P2Y12 inhibitor. The general feeling is from these two trials that probably the NOACs do part of the action of aspirin. In fact, in the trial which you just saw from Dr. Nagendra Bhupati, where the patients were compared to ticagrelor alone versus aspirin, the bleeds are more in the aspirin group. And even in this COMPASS trial, the bleedings were more the gastrointestinal bleeds. Aspirin, in my opinion, is the biggest source of problem. Probably a trial in future where they combine a NOAC low dose with P2Y12 inhibitor might give even more encouraging results. Now, let me conclude that dual pathway inhibition seems to slowly catch up over course of years. With the advent of NOACs, especially in low doses, there is a clear reduction in all events, in all subgroups at the cost of slightly increased bleeding, but not intracranial or fatal bleeds. And combination with P2Y12 inhibitors has to be seen. Thank you very much.
Thank you, Dr. Sarat, for a beautiful presentation. We'll go for next presentation, and think we can have after that some discussion.
Yeah.
Okay, so next will be given by Vivek Gupta about long-term use of P2Y12 inhibitors after PCI.